Good morning. Can you hear me? I feel like I'm speaking to myself. Good morning, everyone. Thank you all for coming here today. I want to start by thanking the Mesothelioma Applied Research Foundation for inviting me to give this talk here. This is almost my third time talking about the exact same subject. And I want to give a shout to my niece. Where did she go? She's a biology student. She's a biology student at the University of Chicago and wants to go into medical school, and trying to recruit her to the mesothelioma research. So thank you for coming. Anyways, my topic here today is about mesothelioma and genetics. I will try not to overwhelm you. By the end of the presentation, you will have my email and my cell phone number, and you can reach me on all sorts of social media for any questions. Of course, we do not use patient privacy and information on social media, but if you need to connect with me, please do. I am employed by ICON Clinical Research. ICON is a contract research organization, so what we do is manage clinical trials on behalf of pharmaceutical companies. I have no actual or potential conflict of interest in relation to this educational activity. I will discuss non-FDA approved medications in the context of clinical trials and what has been done in the field. My objectives today is to try to help you understand the medical use of genetic information. We as physicians and researchers, how we use this medical information, understand the difference between somatic and germline mutations, something you may have heard during the course of this presentation or other ways of TV or social media or educational activities. And then the third thing, understand the implications of detecting a somatic or a germline mutation in cancer patients in general and how that applies to the mesothelioma patients. And then review the biomarker and targeted therapies in mesothelioma. So we as physicians or people in the medical community, how do we use the genetic information in the medical settings? You know, the first thing is try to predict the disease risk based on individual genetic variations. What does it mean for somebody to carry a BRCA mutation or a BAP1 mutation? So trying to understand this risk on the basis of this mutation is important. The second thing, in trying to understand the interaction between this mutation and the environment. What does it mean for somebody who has BAP1 to get exposed to asbestos, for example? What is the mechanism of the disease? Is it different in patients who have, what we call sporadic mesothelioma with no risk factors, or somebody who has BAP1 mesothelioma? And there has been suggested differences. For example, in patients who have BAP1, we think that the prognosis or the outcome of these patients and the progression of the disease is slower in these patients in comparison to the others. Potential development of gene-based therapy, and that is, the future of hopefully treating a lot of the genetic diseases. And the third thing is use of genetic information to guide biomarker selection for treatment, biomarker selection to predicting treatment outcome. There's something in medicine called, pharmacogenetics that can help us understand how does the drug target, the specific mutation or the specific alteration or the specific pathway. And also, how do these drugs, in terms of side effects, behave in the human body? How are they metabolized? So that's the whole idea of understanding the pharmacogenomics and genetics of these drugs and mutations. So the first thing I think is try to go simple by understanding what is a mutation. A mutation is simply an alteration in the DNA that results in a protein that the protein is malfunctional. It doesn't do the job that it was designed to do. And then when we break this down into somatic versus germline mutations, it means on the left side, as an example, that the somatic mutation is something that develops specific in this cancer cell, and it is not something that you inherit from your parents. While on the other side of this slide, you see what does heritable mutation mean? It means it's a mutation that was in the sperm or the ovum and that was transmitted to the child. and it was transmitted to all the cells. Excuse me. The reason it's important to mention this here, because sometimes you may look at the pathology report of the mesothelioma patient and it reads, BAP1 testing was done and it's positive, or BAP1 testing was done and it's negative. I just want you to understand, if you read this, it does not necessarily mean that you have a germline mutation or a somatic mutation. It is just an indication of the protein presence or not presence in in that specific pathology specimen, and whether you should be worried or you should be tested for germline mutation or not. That's something you need to discuss with your doctor. The most common genetic alterations that we have observed in mesothelioma include the BAP1, but there are other ones. There are the NF2 mutation, for example, which stands neurofibromatosis gene. There is, the CDKN2 or cyclin-dependent kinase 2, which affects two proteins called P16 and P14. These are the most common, but there are other ones. What does it mean to carry a BAP1 germline mutation? The first thing is that this has been associated with different types of cancer. Mesothelioma is one of them. It's probably the most common one of them. But there are other tumors that have been found to be associated with BAP1, including uveal melanoma, or they call it retinal melanoma, or eye melanoma is the same term. There's also cutaneous melanoma, skin melanoma, and the fourth or most important one is renal cell carcinoma, or the other easier term to use is kidney cancer. And there are others that the association is not 100% clear, and the field is still evolving to understand, how this interacts with the, with the phenotype, or what tumors the patients develop. These are the established relationships. And also there is another more challenging, topic is, what do these mutations mean when they happen in the context of another mutation? Because some person can have not only BAP1 plus something else. So what does that interaction mean for each individual patient? So who are the patients that we should suspect that they may have a BAP1 germline mutation? First of all, if you have a patient who is young, less than 55 years of age, those patients tend to likely have a germline mutation. If there is a woman with peritoneal mesothelioma, that's another thing to make you suspect that there may be a BAP1 mutation. Patients with relatives with mesothelioma or eye melanoma, what we said, the uveal melanoma, or kidney cancer, possibly can have a BAP1 mutation. Or patients with a strong family history of any type of cancer, they're probably worth thinking along the line that this could be a BAP1 related disease, especially that we said earlier we don't understand all the diseases that can be encompassed under this BAP1 mutation. And of course, less frequently, other germline mutations can cause mesothelioma, like the big circles we put about the NF1, neurofibromatosis, and cyclin-dependent kinase 2. Now, what do we do with these mutations? I mean, are they actionable? That's the most important thing. Okay, you tested me, or you tested the tumor sample, you found a mutation, that is BAP1, what do I do with it? And this has been a subject of investigation, and we'll talk about this later. There are a lot of ongoing clinical trials, as well as, like, if you remember earlier, Dr. Hassan talked about the clinical trials that they have at the National Cancer Institute. And there are clinical trials that already concluded in terms of, what do we do with the BAP1 and how to treat these patients. Unfortunately, I'd have to say the clinical trials so far, and I think somebody asked a question here of how many clinical trials proceed to phase 3, and the answer was like 20%. And that's one of the reasons. You do a phase 1, you get the safety, you do a phase 2, and then you get a surprising result that means the study is not warrant moving further to a phase 3 clinical trial. So olaparib is an example of a BRCA, or a BRCA mutation inhibitor, used and approved in ovarian cancer, for example, used and approved in breast cancer, for example, and pancreatic cancer. And then we thought that may have some activity in BAP1 because of the interaction between BAP1 and another protein called BRCA protein. So it was tested. Dr. Hassan did the study, and unfortunately, especially for BAP1 germline mutation patients, it seems that for olaparib in particular. There are other classes or other drugs like olaparib in the same family that are still being tested, but at least for olaparib, the results were not encouraging. Another drug that has been tested again in phase 1 and moved to phase 2 is called tazemetostat, which is an EZH2 inhibitor. It has been approved in other diseases like lymphoma, but it has not proven to be effective in BAP1 mutated patients. What does this mean? At the end of the day, maybe the drug alone is not effective. Maybe other formulations of the drug, other ways of testing the drug, other combination may prove to be effective, or maybe a subset of patients may at the end of the day benefit from this therapy. But so far, the results are not encouraging either. There is another clinical trial at University of Leicester. I hope I said it correct. And then, this basically looking at multiple mutations or multiple targets in mesothelioma based on genetic alterations. Like in BAP1 or BRCA1 mutated patients, they're looking at another form of PAP inhibitor called rocaparib. Looking at patients with CDKN2 or what we said earlier, P16, INK4 mutations, to look at a drug called abemaciclib, which is a drug that targets a protein. It's called CDK4/6. And there is, of course, pembrolizumab, which is an immunotherapy combined with bimecitinib, in patients who did not have any mutations. And there is atezolizumab immunotherapy combined with bevacizumab, and that's what we talked about earlier, combination therapies, not me, my colleagues, of course, and what Dr. Haymaker will be talking about in terms of immunotherapy environment. This is a paper that we recently published earlier this year that talks about medical and surgical management of patients with BAP1 and their families. It took us about 2 years to publish this paper, but I suggest that you reference to this paper if you want to read further about the surgical management and medical management of BAP1 patients and their families. You have to remember that there are limitations or risk factors or things to consider when you want to do genetic testing. What is the benefit? What is the risk? What are the limitations? So the benefits, the first thing is that it may provide a more accurate cancer risk assessment, meaning you know the risk, you carry the gene, then you are at risk. You can personalize screening. Like Dr. Hassan said earlier, we can recommend certain recommendations because these patients are at a higher risk of developing kidney cancer, so you can try to screen them early to detect and cure those diseases. You facilitate decision making. What do you want to do? Lifestyle, smoking, asbestos exposure, early surgery or clinical trials to try understand the behavior of the disease. The risks. It is an emotional distress. It's not easy for somebody to tell them you carry a germline mutation that is still being investigated. We don't know much or a lot about what we need to do with these patients and what we do with it. The confidentiality concerns, like who's going to get this information? What am I going to do with it? Fear of genetic discrimination. Are you going to be discriminated against in terms of your health benefits? Are you going to be discriminated against in terms of your, disability, life insurance? All of these are important things to consider. There is the Genetic Information Non-Discrimination Act. I'll talk about it briefly. Concern about your family and children. Guilt feeling. Did I pass this to my children? What do I do with it? Who should be tested? And it does not eliminate the cancer risk. Just knowing this, it does not eliminate your risk that you're going to get cancer. The limitations is that sometimes uninformative is negative, meaning if you test and you're negative, it doesn't mean you're not going to get mesothelioma. That's it. No, nobody knows. The second thing, there's sometimes variants, what we call of uncertain significance, which means you can find mutations in BAP1 or other forms of genes that we don't know what's the relation between these genes and the risk of mesothelioma. So what do I do with it, doc? I don't know. We just need to watch you. The positive results cannot predict cancer diagnosis. You have the results. When do I get this? Do I get it before 40, after 50? How do I plan my life? Testing minor is usually not recommended. This is what I said earlier, the Genetic Information Non-Discrimination Act. What you need to know is that, it protects you against discrimination from health insurance companies and employers. However, there are some limitations to that too, just like everything else in life. You know, the employees of companies that are fewer than 15 employees, you know, does not protect them. You know, if you are a military or federal employee, it does not protect you. You know, specialized insurance companies like TRICARE, Indian Health Service, or you know, life insurance. You can be denied life insurance on the basis of this information if they knew it. The second question is disability. The second thing, disability or long-term, you know, care insurance. This is before I, of course, pass it over to Dr. Haymaker. Just shows, you know, similar to the slide that was shown by Dr. Hassan about, you know, the progress or the trials that have been done. In 2003, just a historical perspective, we used to only have cis and pemetrexed, or cis alimta. Some of you know it in that name. Then in 2008, we started testing the alteration of neurofibromatosis too. Then mesothelin as a target came on the pathway of treating cancer. Then another marker called ASS. Then PD-L1 in 2016 became available to test in this context. Then we tested VEGF inhibitors like Avastin as a target. And then WT vaccine, which is Wilms tumor 1 vaccine pertinent to mesothelioma patients. Then in 2018, we started testing, you know, BAP1, and what we said earlier, unfortunately, the results so far have been negative. Then we introduced other immune markers like, you know, B7H3 and VESTA, or CDK4 CDK4/6 inhibitors. And then until 2020, that's when immunotherapy combination became available using nivolumab and ipilimumab. Cisplatin and Alimta, or cisplatin and pemetrexed, remains available. And right now, there are a lot of combination therapies that are being explored: immunotherapy plus chemotherapy, immunotherapy plus VEGF inhibitors, immunotherapy plus other targets, and the search continues for new therapies. Thank you.
And then we can do Q&A
Sure.
after. Thank you so much. All right. Hi, everyone. Good morning still, just barely. I'd like to thank the organizers for the opportunity to present some of what we are doing to deconvolute the immune response in malignant pleural mesothelioma, and hopefully be able to answer any questions you guys might have as it relates to where we are going in terms of new therapeutic strategies based upon identifying actionable targets. So with the intent really being to look in a tumor, in an individual's tumor, and say, okay, that's a target that we know exists, and therefore that can guide therapeutic strategies. In terms of disclosures, I have nothing relevant to disclose pertaining to this talk, but I do receive funding for other studies from a few different pharmaceutical companies that are listed here. And also, I am on the scientific advisory board for the Mesothelioma Applied Research Foundation. So just as a brief outline of what I want to talk to you guys about today is really, you know, does the immune system actually play a role in mesothelioma? Then how do we identify distinct immune signatures within the tumor microenvironment so we know what to target, right? And we're not just going in blind. And then how can we then use that information to really identify these targets, see if they are actionable or not, and then with the intent of reinvigorating the immune response to fight the tumor and help improve our patients. So this was an amazing seminal study that really demonstrated that, in fact, the immune system does play an active role in malignant pleural mesothelioma. This is the Lancet Oncology paper that compared nivolumab plus ipilimumab, so two immunotherapy combinations that are targeting two checkpoints that are found on T cells, versus chemotherapy. Now, what was amazing about this checkpoint 743 study is that it told us two major things, and I'm going to hopefully try to use do I get? Aha, okay. The first thing that it told us is that the immune system is playing an active role in mesothelioma. And we can see that because when we treat patients with this combination, we are able to improve their overall survival. And that is as compared to the chemotherapy alone group in red. Now, what was even more informative is a subgroup analysis based upon the type of tumor that these patients had. If it was an epithelioid malignant pleural mesothelioma, there was actually no benefit to this combination as compared to chemotherapy alone. However, if you had a non-epithelioid histology, so this could be a biphasic or a sarcomatoid, you saw a dramatic improvement, as you can see here in blue versus red, in terms of patient survival. Now, this told us another important point in terms of selection of patients and who should be treated with this combination, right? Because if you're going to have a non-epithelioid type of tumor, this is a great therapeutic option. If you have an epithelioid lesion, the search is still on in terms of improvement related to chemotherapy. Now, when we think about the immune system in a tumor, it is an amazingly complex microenvironment. There are numbers of different types of cells that can be present within every individual tumor. These can involve very good cytotoxic cells that are here to kill the tumor. These are called NK cells or CD8 positive T cells. And these cells are the cells that we are really trying to allow to kill the tumor and release brakes that the tumor is putting on those cells to shut them down. Because from the tumor perspective, it doesn't want to be killed, right? So it's going to throw up all of these barriers that are going to cause the immune system to not see it or to not effectively kill it. So that is the role that we have to understand, is what are those barriers that the tumor is actively using? And then that can allow us to know what can we block to then allow those T cells or those immune cells to then be able to exert their function. Now, the way we are approaching this at MD Anderson is for every surgical case that we receive where a patient consents to allow us to use their tumor in this way, we are basically doing everything we can to deeply profile the immune system within that tumor. We are looking at how the cells interact with each other. Is a T cell trying to kill a tumor cell? We can actually see that. We can stain for those cells and we can look at how close they are to each other and whether or not that T cell is really, giving it its best, but maybe the tumor cell is actually suppressing that. We are also able to understand what cells are even in the tumor. Do we have an immune response in this tumor? Not all patients have an active immune system response to a tumor. So that can tell us maybe there's ways we could try to promote that. Adoptive cell therapy strategies or giving cells that would actually be able to recognize a tumor. We can also, as was mentioned earlier, we can look at genetic components that can be good readouts for us to understand how that interplay occurs with the immune system. And then we can also even expand cells from tumors to then look at how they interact with the tumor itself. So that allows us to understand the immune function. Now, when we do this, I just want to show you guys kind of what the different ways this data comes out and what it looks like. When we look at tumor-associated tissue, so this is tissue that does not contain the tumor, but it's coming from the surgery at the same time, and then the tumor tissue itself. These are epithelioid patients, and what you can see here is that we have a lot of immune cells actually in the tumors from our patients with epithelioid malignant pleural mesothelioma. But you can see that's a wide variety. Each of these dots is an individual tumor. And so when we look at this, you can see some patients have a very, very, very high degree of immune infiltration, and some actually have what we call a cold tumor microenvironment, meaning that the immune system doesn't seem to see it yet. Now, when we look at those other types of cells that could be present, we can see very, very good T cells and very good cytotoxic cells. So again, these are the the foot soldiers of the immune system that are really here to try to kill the tumor. And we can see that they are very present within these microenvironments. And then we have other types of cells that I'm going to just very, very briefly touch on that are called myeloid cells. These are the cells that actually will instruct the cytotoxic T cells to kill a tumor. And so these are very important targets for us to consider as well in terms of allowing the T cells and the cytotoxic cells to be able to kill the tumor itself. Now, when we look at other types of cells that could be in the microenvironment, we can see that there are also suppressive cells that are there. This is a cell type called a T regulatory cell. As you can imagine from the title being regulatory, it's actually there to suppress the good T cells that are trying to kill the tumor. And we can see that in some of these cases that we have a high frequency of these suppressive cells. So this kind of makes us think about different ways that we could shut these cells down to then not allow them to exert that regulatory function. On the good note, though, we do see that we also have a lot of actionable targets. As I mentioned before, there was exciting data related to the blockade of CTLA-4 and PD-1 in the CheckMate study, but those are not the only checkpoints that can be found on T cells. And we see that really clearly when we look at these cases here, where you see a lot of PD-1. So this is the target for the nivolumab. We also see CTLA-4. This is the target for the ipilimumab. But there are other targets that we are still in the process of understanding if we can test if these are going to have good outcomes in our patients. LAG-3, for example. TIGIT is another one, and TIM-3. And so we actually have drugs that are allowing us to target all of these pathways that are in different stages of being tested to see if we can improve our patients' outcome and survival. And you can see that this is also true on on our cytotoxic T cells as well. So this would allow us to relieve those breaks and have a good outcome. Now, as I mentioned before, not only looking at phenotypes, we also want to understand who's actually talking to who in that microenvironment. This is really critical for us to understand if the immune system is engaged, not just there because it's just passing by, but really engaged in trying to kill the tumor. And there's a physical interaction that we can assess using different types of pathology settings. This is called multiplex immunofluorescence, where we're staining for different cell types within fixed tissue, and we can look at how those cells interact with each other. So for example, when we look at, let me see if I can see here. When we look at, sorry, I've lost myself in this slide. Okay, when we look at our myeloid cells, you can see them here. We see that they are also interacting with tumor cells. They're right next to each other. And so that means those cells are actually talking to each other and giving each other feedback that could be important for us to understand how we might want to interrupt that and then allow a normal immune response to occur. We are also able to utilize other types of strategies like RNA sequencing. Using this type of strategy, at least in the patients that we have profiled so far in these tumor cases, we see two very clear colors, right? You see a red square and you see a blue square. These are epithelioid cases, and we find that we have two very specific, distinct buckets of immune responses that are found across these two different cases. And this allows us to understand then maybe patients that have this type of a expression pattern might benefit from one therapy versus patients that have this blue expression pattern might benefit from another therapy. So what we can see from our overall data that we're generating so far is that we have, again, these kind of two overarching immune buckets. We have some cases where we have a very, very, very active immune response with a lot of checkpoints and a lot of actionable targets that are very druggable. And so you can imagine that in this context, we can explore other types of ways to release that immune brake. And this can involve things like I mentioned earlier, such as TIM-3 or TIGIT or LAG-3. We can also target other axes that involve PD-1. We can actually target the ligand for PD-1 that can be found on the tumor cells and on the myeloid cells. And this could result in a good outcome. Now, for those cases that I mentioned that are the cold tumors or the blue tumors that I just showed, in that case, you know, it seems like there's not a very engaged immune system. So we need to really think about strategies to reinvigorate that. And that can involve scenarios where we're able to grow out cells that are able to recognize the tumor and then give them back to our patients, and thereby restoring that anti-tumor immune response through adoptive cell therapy strategies. And that way we're then able to push that system, right, and kind of restart that response. And so that's the way we're kind of thinking about this and how we're building this data to hopefully then have a really beneficial clinical outcome. So I just wanted to briefly thank everyone for their time and attention, and also the work that I just showed. It takes kind of a village to really delve deeply into understanding what is happening in this complex microenvironment, and then really think about what are we able to utilize to change our therapeutic strategies. We have a very active working group at MD Anderson that we call MIG. It's our Mesothelioma Immunogenomics group, and this is a multidisciplinary team that we are utilizing to really try to tackle some of these challenges that we face, and also being able to understand how we can apply these actionable targets that we identify into a clinical trial setting. And then, of course, all of the patients and their families without whom none of this could happen because of their generous contributions towards the research. So thank you all for your time and attention.